Okay, I think we'll go ahead and get started. Can you folks hear me? I'm really delighted to have Dr. Meredith Shiels with us. She's from the intramural program at the National Cancer Institute. She's in the Division of Cancer Epidemiology and Genetics, and within the infectious and immunoepidemiology branch, where she is a tenure-track investigator. Dr. Shiels earned her master's in health sciences and PhD in cancer epidemiology from the Johns Hopkins Bloomberg School of Public Health. And actually, her research is really quite interesting, fascinating. She's going to be talking about an area that she's no longer doing that much research in. But I guess her passion is really looking at risk factors that might explain some of the trends in cancer that people don't think about. And so some of the for example, she had talked to me this morning about the fact that she was looking at trends for bladder cancer that may not necessarily be explained by smoking. So smoking is associated with bladder cancer, and what you would expect is that there's a decrease in the trends in bladder cancer since there's been a decrease in the prevalence of smoking, but you don't see that. So trying to find what are some of the factors that might explain that is some of the interesting work that Dr. Shiels is doing. But today she's going to be talking about some work that she had done in the area of smoking and tobacco. And the reason why her work is important, especially in the tobacco area, is because since the passing of the Tobacco Control Act that gives FDA jurisdiction over tobacco products, it becomes really important to know what the harms are that are associated with some of the emerging tobacco products. And so when I talk about emerging tobacco products, I'm talking about products like electronic cigarettes, or more recently it's going to be the heat not burn tobacco products. So they heat the tobacco rather than burn it, so there'll be less combustion. We can't wait years and years to determine what the impact of these new products might be, and so what we do need are biomarkers of harm. And that's an area that Dr. Shiels has made some contributions in with regards to the inflammation biomarkers. And so actually I met Dr. Shiels at an FDA workshop on biomarkers of harm, and Stephen Hack said, oh, we need to invite her to come in and talk to us, because one of the areas that we want to expand in is trying to look at inflammation biomarkers that are associated with tobacco. So I'm really delighted to have her here today, and she will be talking about circulatory biomarkers of inflammation and subsequent risk of lung cancer. So Dr. Shiels.
Good morning, everybody. Thank you for being here today, and thank you to Dorothy for inviting me. It's a great honor to be here and present some of the work I've done on circulating inflammation markers with regard to cigarette smoking and lung cancer. I'm going to start my talk today with a very brief background on prior work in inflammation and lung cancer, and then turn to two studies based in the U.S. that I've carried out looking at circulating inflammation markers and the subsequent risk of lung cancer. I'm then going to discuss cigarette smoking and these inflammation markers, and conclude with a few slides describing work that that's almost completed regarding circulating inflammation markers and lung cancer risk among never smoking women in China. So lung cancer is of course, very important type of cancer in the U.S. and worldwide. It's the most common cause of cancer death, and the second most common incident type of cancer in the U.S. among both men and women. Of course, it goes without saying that cigarette smoking is the predominant risk factor for lung cancer, causing about 90% of cases. But there is emerging evidence that inflammation may also play a role, both in the setting of cigarette-induced lung cancer and also in the setting of lung cancer among never smokers. So just a very quick review of some studies that have shown associations between risk factors related to inflammation and lung cancer risk. Studies have shown associations between genetic variants in the inflammation pathway with lung cancer, medical conditions that are known to be inflammatory, such as tuberculosis, chlamydia pneumoniae, and chronic obstructive pulmonary disease. Circulating markers of interstitial lung disease or lung damage, such as pro-surfactant protein B, surfactant protein D, and Krebs1 Lundgren 6 have also been associated with lung cancer risk. And finally, and related to what I'm going to talk about today, some circulating markers of inflammation have been shown to be associated with lung cancer risk. Many of the studies prior to our work really focused on just a handful of markers, the most common being C-reactive protein, which is a general acute phase protein, general inflammation marker that can be used clinically. So there's a clinical assay to test for CRP. So a lot of the original work in this area started with CRP. So the aim of the first two studies I'm going to show you were to first assess the association between circulating inflammation markers and lung cancer risk using two case control studies set in the prostate, lung, colorectal, and ovarian cancer screening trial, which I'll describe in a moment. And the second was to then take those results and assess the utility of those inflammation markers in risk stratification for lung cancer screening. So we really had an etiologic aim and then also a more applied aim, trying to assess whether these markers could be useful in identifying people at highest risk of lung cancer in a more clinical setting. So as I mentioned, these first two studies were nested within the prostate, lung, colorectal, and ovarian cancer screening trial, which some of you may be familiar with. The study recruited 155,000 men and women aged 55 to 74, mostly in the 1990s. Participants filled out questionnaires collecting demographic, behavioral, and dietary information. And then in the screening arm of the trial, where screening for prostate, lung, colorectal, and ovarian cancer was ongoing, blood samples were collected at baseline and then in annual visits for five annual subsequent visits. Cancers were ascertained through questionnaires and followed up with a medical chart abstraction and death certificate review. The circulating inflammation markers that I'm going to describe today were measured using a Luminex bead-based assay that measures multiple markers simultaneously. It includes immune markers with many functions and requires a relatively small amount of specimen for the number of markers that we were able to measure. Before undertaking these studies and a series of other studies within our division at the NCI, a methodologic study was done testing this platform against some others and found good reproducibility of the markers using this Millipore series of panels. The markers tested in this study are listed here, and we tested 6 different panels of inflammation and immune-related markers for these lung cancer studies. Now, I'm going to describe 2 studies that were independently conducted, but both within the setting of the PLCO. So the first study, which I'm going to refer to as our discovery study, included 526 lung cancer cases and 592 controls. Because we wanted to understand the independent contribution of inflammation to lung cancer risk, we carefully matched these cases and controls to each other by age, sex, follow-up time, randomization year, and importantly, and something to keep in mind, by smoking behaviors. So we matched by smoking status, and then among former and current smokers, pack years and years since quitting. Current and former smokers were matched 1-to-1 cases to controls, and never smokers were matched 3-to-1 to give us a little bit more power to examine some associations among never smokers. In the first study, which was published in 2013, we measured 77 circulating markers of inflammation that I just showed you in the prior slide in pre-diagnostic serum samples. The second study, which I'm going to refer to as the replication study, was a completely independent set of cases and controls, again within the PLCO, matched on very similar characteristics. And then in the second study, we measured 51 markers. We got rid of some of the markers from the first study that didn't perform as well as we had wanted them to. And so we measured a smaller set in the second study, and that was published last year. This slide shows the characteristics of the cases and controls from the replication study and also the discovery study. So you can see, so the first two sets of columns are the cases and controls from the replication study, and then the second two from the discovery study. You can see that these cases and controls were matched very closely on age. There wasn't much difference by sex. Smoking status, the numbers don't look like they exactly line up, but that's because we matched never smokers 3-to-1 and current and former smokers 1-to-1. And then, of course, smoking behaviors are almost identical. So these cases and control sets were very closely matched for these characteristics. For those who might be interested in the actual analysis we did, we used conditional logistic regression, adjusting for a number of factors in addition to those that are already controlled for in our matching scheme. We analyzed the markers in categories based on their detectability level, either 2, 3, or 4 categories. Most of them were analyzed in quartiles because they were high detection markers. So this slide shows the 11 markers that were significantly associated with lung cancer in our discovery study. They include acute phase proteins, a soluble receptor, cytokines, a growth factor, and chemokines, all listed here. For the most part, associations were in the positive direction, so higher levels of these markers were associated with higher lung cancer risk, with the exception of interleukin-1 receptor A, which was inversely associated with lung cancer. Now, the results shown in blue are from our replication study. So we measured 50-plus markers in the second study, but I'm only showing you the markers that already were associated in our first study. So of those 11 markers, you can see that 4 markers replicated in the second study. Again, with the same direction of increased risk with increased marker level. So that includes C-reactive protein, serum amyloid A, soluble tumor necrosis factor receptor 2, and the chemokine CXCL9. So in both the discovery and replication study, these markers were significantly associated with an elevated risk of lung cancer after carefully controlling for smoking behaviors. We then looked at these markers. We pulled the data from the 2 studies together and looked at these markers by latency, which is time from when the blood sample was drawn to when the lung cancer occurred in the cases, and in the controls, it's from the time of blood sample to when they were matched to their case. One thing to note is that for these p-values for interaction tell us that there's no significant difference in the estimates with increasing latency. So less than 2 years, 2 to 4, 4 to 6, and 6 plus. So from a statistical perspective, there was no difference across these categories. However, if you look at the individual estimates, you can see for CRP, serum amyloid A, and CXCL9 that these associations remained fairly strong even up to 6 years prior to lung cancer diagnosis. For soluble tumor necrosis factor receptor 2, the associations appeared to only really exist in the less than 2 to 4 years prior to diagnosis. So for 3 of these markers, it really seems like these associations precede lung cancer by 6 or more years in our analyses, which is important whenever you think about what is the driving forces behind these associations and whether or not we're simply just detecting markers that are thrown off by a tumor itself, or whether they're etiologic markers that actually precede the development of lung cancer by many years. We then took those 4 markers that replicated and created an inflammation score. So in the discovery and replication studies separately, we used a technique called 5-fold cross-validated logistic regression to estimate a score for each individual in our study based on their values of these 4 markers, and then generated quartiles again of these scores. So for the discovery study, the replication study, and the pooled estimate with the 2 studies combined, you can see that those in the highest quartile of the inflammation score had about a 2.5-fold increased risk of developing lung cancer compared to those in the lowest quartile. So again, this score is based on levels of CRP, SAA, STFR2, and also CXCL9. So to put our results all together and think about what they may mean, I created this table just to go over a few of the some information about the markers and then some explanations about what we might be seeing and what might be causing it. So C-reactive protein, as I mentioned previously, is a acute phase protein. It's a generic response to inflammation, and it's generally produced by liver cells, and the function is clearance of necrotic and apoptotic cells, as well as just being a general actor in cytokines. Serum amyloid A is also an acute phase protein, again, primarily produced by liver cells, functions in the transport of cholesterol, immune cell recruitment. Soluble tumor necrosis factor receptor 2 is a receptor for pro-inflammatory cytokine, TNF, and it's produced by a number of cell types, and it's anti-apoptotic. CXCL9 is a chemokine produced primarily by macrophages, and it's involved in T-cell trafficking and is anti-angiogenic. So you can see that these markers have different functions, but they all seem to be associated with lung cancer risk. So the next question is, are these truly associated with future risk, or are we missing something? Is there some other explanation for why these markers would be associated? So one question is, are these markers associated with lung disease or damage that we know is already a risk factor for lung cancer? So you can imagine that maybe these markers would be marking some underlying undiagnosed lung disease or damage that's already associated with lung cancer. So all we're really picking up is that lung disease or damage. And in the literature, CRP, SAA, and CXCL9 are all associated with lung diseases such as COPD, sarcoidosis, idiopathic pulmonary fibrosis. So it's possible that these markers may be picking up some underlying lung damage. We did adjust for a personal history of bronchitis and emphysema in our model, but it is possible that there's some residual confounding or some other underlying lung diseases may be driving some of these associations. Another question is what I mentioned previously. Are these actually just being produced by the tumor cells themselves? Are we just picking up tumor markers rather than etiologic markers that are associated with subsequent lung cancer risk in individuals? And for SAA, STNFR2, and CXCL9, the answer is yes, they are produced. There is evidence that they can be produced by tumor cells. Now, we don't think that this is the full explanation based on what I said before. Based on latency, these markers are detected a number of years prior to lung cancer diagnosis. And the other, perhaps somewhat reassuring thing is that if they were produced by the tumors, you would imagine that a larger tumor would have a stronger association between the marker and lung cancer because there would be more of whatever marker we were examining, but we didn't find that to be the case when we looked by stage and tumor size in this analysis. So we think there is some evidence for an etiologically relevant contribution of these markers to lung cancer development. And the second question that I said we wanted to address with these studies are, do these inflammation markers have utility for risk stratification? When I say risk stratification, I mean identifying people at highest risk of subsequently developing lung cancer. And the reason that this is particularly relevant in recent years is that just in the last several years, the U.S. Preventative Service Task Force now recommends annual screening with low-dose CT scans. The recommendation is for 55 to 80-year-olds with 30-plus pack years history of smoking and less than 15 years since quitting smoking. These recommendations are based on the results of a study, the National Lung Screening Trial, that found that LDCT or low-dose CT scans reduce the risk of lung cancer death by 20%. And the recommendations are generally based on the screening or the entrance criteria of the NLST. So that's where the recommendations come from. The problem with LDCT is that there's a lot of false positives. There's need to follow up on those false positives. And there's also exposure to the low-dose CT scans. So there has been some question in the literature about whether these are the best criteria for entrance to getting a low-dose CT scan, and whether another approach to identify people at highest risk of lung cancer would be preferable. And so there have been a number of studies that have looked at risk-based models, so using more refined characteristics of the people who would be eligible for lung cancer to determine whether or not they're at highest or lower risk. For example, if you look at these criteria, you would imagine somebody with 100 pack years of smoke experience who's a current smoker and 75 is probably at a higher risk of lung cancer than a 55-year-old that just barely meets the other criteria. So there's a lot of variation in risk within the risk group, and you may also imagine a 54-year-old that has an extreme smoking history that may actually have a higher risk than some people who actually meet the criteria. So that's where the risk-based models come in. And the question that we had was that in addition to these risk-based models, would our markers add anything? Because these could be measured in circulation and perhaps help stratify people based on their risk. So bear with me as I explain what we did next, and I'm happy to answer questions after because it is a little bit confusing. To assess whether a risk-based model and a risk-based model plus markers improved upon just the general criteria, we started by reweighting our studies to the full PLCO arm. So each individual that had measured markers was weighted up to the full PLCO arm. We then, PLCO screening arm, excuse me. We then said, in the whole screening arm, how many people would meet the criteria for lung cancer screening? And the answer is 15,076, based on those criteria that I presented to you. We then said, okay, if we're going to screen 15,076 people, can we do a better job if we then use risk-based estimates? So we have our 15,076. We then use risk-based models to estimate 5-year probability of developing lung cancer based on age, sex, pack years, and time since quitting. So we took everybody in the screening, reweighted to the screening arm, calculated their 5-year risk, and then ranked them and took the top 15,076. We then did the same thing with models that also included CRP alone, because as I mentioned, it's already a clinically available assay, so that would be relatively easier to incorporate into practice than some of these other markers. And then we did a model that was risk-based plus inflammation score. So again, for each of these 3 scenarios, we calculated 5-year risk, took the top 15,076 riskiest people, and then saw how many lung cancers we would catch in each of these scenarios. So it's not testing screening itself, it's really getting the sensitivity of the cutoffs or the inclusion criteria based on these different approaches. So to try and explain, so as I said before, we're saying if I can only screen 15,076 people, which approach would consider the largest number of lung cancers to be eligible for screening? So we're really looking at sensitivity of the approaches here. We looked at sensitivity, specificity, positive predictive value, and negative predictive value. I'm just going to show you the results for sensitivity. So to walk you through these, we had 916 lung cancer cases in the screening arm. So if you just use those criteria, that USPSTF criteria, which was 55 to 80, 30 plus pack years of history, and less than 15 years since quitting among former smokers, you would capture about 68% of the lung cancers in those eligibility criteria. So it's a decent fraction of the lung cancer cases, but there's certainly room for improvement. If we then use a risk-based model, which is this second bar here, we shoot up to around 75%. And this p-value shows you that that's a statistically significant difference from just the original screening criteria. So adding a risk-based approach that takes an individual's pack year, history, time since quitting, age into account definitely improves the sensitivity of being able to capture lung cancer cases in using this criteria. We then added CRP and saw a very minimal increase that was not statistically different than this risk-based alone, and the same thing with the inflammation score. So it doesn't appear that the incorporation of these markers into risk-based models really improves sensitivity of the criteria for identifying lung cancer or identifying individuals for lung cancer screening. Another way of looking at this is just look at the lung cancers and see how people are moving in and out of the, I'll go over here to be equal, to how people are moving in and out of the screen, not screen categories or the low and high risk categories based on these different approaches. So if you just use the recommendations, this is the 916 cases, and as I said before, it's about 68% would be in the high risk group for screening. If you then move to a risk-based model, there are 128 people that were low risk up here that then moved into the high risk category. But there were 63 that moved from high risk to low risk. So a net gain of about 60 additional lung cancer cases would have been screened in this scenario, which is good. And it's an improvement. We then move to CRP plus the risk-based model, and we see this is compared to this. We see only a net movement of 6 cases, so it's not adding very much. And similar for the inflammation score, it's not adding all that much compared to the models above. So we had a lot of hope for these markers, given their association with lung cancer, that they may contribute to identifying people for LDCT screening. But in the end, it didn't seem like they would contribute very much to beyond a risk-based model, which has already been shown in the literature several times to improve upon just the general criteria that are being used right now. So from our first 2 studies, we found that circulating levels of CRP, serum amyloid A, soluble tumor necrosis factor receptor 2, and CXCL9 were prospectively associated with lung cancer after adjusting for cigarette smoking. And it's not independent of cigarette smoking because, as you saw, most of the cases here were either current or former smokers. But it does suggest that interindividual variability in the inflammatory response among ever smokers is associated with lung cancer risk. So it may still be inflammation driven by smoking, but we're controlling for those smoking behaviors in our studies. We found that these markers may not be the most useful for risk stratification, and that future studies may want to look at markers that are more related directly to the tumor, more specific to lung cancer for risk stratification. Studies are needed to understand the role of inflammation in lung cancer among never smokers, because that seems to be a different etiologic process. Okay, so I'm bringing this slide back up because when you're talking about lung cancer, some people will never be convinced that your association is not just residual confounding by smoking, because it is such an intense and important exposure for lung cancer. So we needed to fill in this blank too. What was associated with smoking? Which markers were associated with smoking? And could it be that even with our very tightly controlled study that we're still seeing an impact of smoking on our results? So we did an additional study, which I'll describe to you in a minute, looking at cigarette smoking in the circulating marker levels circulating levels of inflammation markers. So cigarette smoking, of course, is a potent carcinogen. It causes cancer at many sites as well as a range of other chronic diseases. It leads to a number of pulmonary and immunological changes, including the frequency and function of many immune cell types. And it also alters the circulating levels of some inflammation markers. As with our lung cancer study, most of the prior work on cigarette smoking and circulating levels was really limited to a handful of markers, again, CRP being the one that people measure most frequently. So here's a couple examples of prior studies that have looked at markers of immunity in circulation. The total exposure study found smokers had increased white blood cells, CRP, and fibrinogen, and found associations with cigarettes per day, duration, and nicotine equivalents. In a study published this year, the VITAL cohort found associations between CRP and prostaglandin M among cigarette smokers and with those who smoked more than 18 pack years. So the aim of this study was to use the same platform I described previously to look at the association between cigarette smoking and circulating markers. Again, this was carried out in the PLCO, and it actually was what we referred to as a value-added study. So we took data that already existed from 3 already conducted case control studies, the first being the discovery study that I just described to you, then a study of non-Hodgkin lymphoma and ovarian cancer, and we combined the data from these 3 studies. Now, these 3 studies in isolation and in combination are not representative of the PLCO screening arm, and that's because, for example, in a lung cancer study, you have a lot of smokers, so there are way more smokers in the lung cancer study than the PLCO screening arm. The ovarian cancer study obviously only includes women. So in order to make this combination of markers meaningful, we combined them and then applied statistical weights similar to what I just described for lung cancer to get these, make our study representative of the full PLCO cohort. So each individual was assigned a weight so that we're able to make inferences at the population level of the screening arm rather than just based on these 3 studies. So to show you how that works in practice, once the weighting is done, here is we had 1,819 people with marker levels. They were weighted up to 58,000 in the screening arm. And you can see, for example, smoking is the best example. So within our measured cases and controls, there were 22% were current smokers. Now, in the full PLCO screening arm, it's only 10%. So, but once we applied statistical weights, in the screening arm it was 10%. Once we applied statistical weights to our sample, we also had 10% smokers. So this is really a statistical way of getting back up to the characteristics of the full screening arm. We first compared current to never smokers. Our outcome was markers that were above versus below the median level. We adjusted for a number of confounding factors. And we found that of the 86 markers, 19 were significant at a p-value less than 0.05, and the 10 that I'm going to highlight here passed the false discovery rate criterion. So we think they're just not false positives based on multiple testing. We think that these may be true associations. And these markers include soluble receptors, stem cell factor, some cytokines, some chemokines, and CRP. We then compared former versus never smokers, and of those 10 markers, 4 were still altered among former smokers. So for some of these markers, among former, they were no longer different from never smokers, but for 4, they remained. One thing I should have mentioned on the last slide, which I'll point out here, is the direction of the association for many of these markers. For most of the markers associated with cigarette smoking, so I'm talking about the blue here from the prior slide, marker levels are actually lower among smokers than among never smokers. So it seems that they have decreased levels of many of these markers, with the exception of the chemokines and CRP. We then looked at smoking intensity and duration among current smokers and found no associations with cigarettes smoked per day and limited associations with smoking duration. So in looking at these results, it's important to keep in mind a couple limitations of the PLCO study. So when they collected information about cigarettes smoked per day, they asked in categories. So when I say there's no association with cigarettes smoked per day, the lowest category was 1 to 10. So it's possible that at lower levels there may be an association, but not from 1 to 10, 10 to 20, the categories that they were collected in. So we're kind of limited by how the data were collected in that sense. And for smoking duration, we're talking about a group of people who are similar age at baseline and who all started smoking at a similar age. So our duration range was relatively narrow. So it's possible if you had smokers that these were not recent smokers. You might have smokers who, if you had more recent smokers, maybe we would have seen more of a difference in the immune marker profile. We then looked among former smokers to understand how marker levels were different across across categories of time since quitting. So for 6 of the markers, there were significant trends, those 6 markers listed. And by 20 years post-quitting, most of these markers appeared to be similar to those of never smokers. So I'm going to give you 2 examples of patterns that we saw. So this first one is for the chemokine CCL17, and this is a similar pattern seen for the other chemokine CCL11. So keep in mind that this is not the same smoker over time. This is a cross-sectional study, so the current smokers are different people from the people in each of these categories. But we saw among current smokers significantly elevated levels, and then across categories of time since quitting, the levels decreased to where we are very similar to what we saw among never smokers at 20 years post-quitting, or even earlier. In the opposite direction for interleukin-1RA and similarly for IL-15 and IL-1B, again, markers were significantly lower in current smokers, but with years since quitting, approached levels of never smoking by the end of the time period. One anomaly was CRP, in that we saw significantly elevated levels in current smokers, and then in recent quitters, we saw this huge jump before coming back down and coming back to levels of never smokers. And this is a unique pattern, but what we think is happening here is that CRP, as I said, is a general marker of inflammation, and perhaps people who are recent quitters are quitting for a reason. They have underlying heart disease, for example. They may quit smoking, which would make them recent quitters, and they would also have high CRP levels. So we think, and this has been seen in other studies related to time since quitting, where there's risk right after quitting of morbidity or of death, and it's related to quitting for cause. There's a reason why those people are quitting smoking in some cases. So there were 6 markers where there were significant trends of categories, across categories of time since quitting, and then there were 4 markers with no significant trend that seemed to remain at an intermediate level between current and never smokers among former smokers. So as I mentioned, this population, there's some limitations of this study. If you're interested in the immune effects of cigarette smoking, these were all older, long-term smokers. We didn't have recent smokers. We didn't have young people with limited ranges of duration and not the most refined classification of intensity. It's a cross-sectional design, so it's important to remember that we're not following an individual over time and getting their trajectory of marker levels. These are comparing never smokers to current smokers to former smokers, all measured at the same time, but they're different people. And as with all these studies, we have to remember these are circulating levels, and it's not clear whether they reflect local inflammation in the lung, for example. And of course, it needs to be replicated, as this was the first study, epidemiologic study of this scale to look at this question. So in summary, we observed associations between smoking and 10 markers of inflammation and immunity with various functions. The results suggest that the effects of cigarette smoking are largely immune suppressive. Most of the markers were decreased among current smokers. There appears to be a low threshold for the effect of smoking on circulating markers, as we didn't see a dose response with intensity. But as I mentioned, there could be a dose response within that first category of 1 to 10 cigarettes per day. We don't see. For some of the markers, levels approach those of never smokers with increased time since quitting, implying that perhaps these markers revert back to levels of never smoking over time. But for some of the other ones, markers seem to remain at an intermediate level among former smokers. And more research is needed to replicate these results longitudinally, so within an individual over time, and to understand how the inflammation markers may mediate the association between smoking and lung cancer. That's not something that we could look at in our lung cancer study because of the design. We really were trying to get rid of the smoking effect in our lung cancer study, so we are unable to look at sort of the mediation hypothesis of inflammation on smoking and lung cancer. Okay, so going back to our little table for our PLCO lung cancer studies, of those 4 markers, only CRP was associated with smoking in our study. So that gives us some reassurance that, at least for the other markers, we don't think that this is residual confounding by smoking being an explanation for the associations between those markers and lung cancer. Okay, if you're still with me, I'm going to go through one more study, which is a little bit different. It's in a different setting, and it's a different disease in some ways, even though we're still talking about lung cancer, which is, we're going to talk about these circulating markers and how they relate to lung cancer in Chinese female never smokers. So we know smoking is, of course, the primary driver of lung cancer incidence, particularly in this country. But there's an interesting increased risk of lung cancer among Chinese women who are never smokers. And this is in spite of the fact that only about 4% of Chinese women in China smoke. And you can see this is from Globocan 2012. It's a map of lung cancer incidence in women. And you can see that China has high levels of lung cancer among women, similar to the U.S. In Europe and Australia, in spite of the fact that smoking levels are lower there. And some of this, there's been a lot of research, particularly in the division that I'm in, about this increased risk. And some of it is attributed to poor indoor air pollution from indoor cooking, coal burning stoves, poor ventilation. So it's an environmental exposure within the home. And but inflammation may also play a role in the etiology, both through that mechanism and perhaps through others. To investigate the associations between circulating markers of inflammation and lung cancer in never smokers, we went to the Shanghai Women's Health Study, which recruited 75,000 40 to 70-year-old women from 7 communities in urban Shanghai during the 1990s. The women in the studies participated in questionnaires, in-person interviews, and also self-administered questionnaires, and provided both blood and urine samples. And for this particular study, we individually matched cases and controls based on follow-up time, birth date, and date of sample collection, and measured 65 markers. These are just a few of the characteristics of lung cancer cases and controls. You can see no significant difference by age. And then I also listed out a few lung cancer risk factors here, so no difference by passive tobacco smoke exposure, no difference by history of chronic bronchitis, family history of lung cancer, use of coal as a cooking fuel, and also poor ventilation. Of the 65 markers, we identified 9 that were significantly associated with lung cancer. This is a different set than we saw before. I wanted to point out 2 findings, the first being soluble IL-6 receptor, which is the one listed here at the top. This was our strongest finding. You can see it has a very small p-value. It passed test for corrections for multiple comparisons, and I'm going to show you some results by latency for this marker as well. The other thing I wanted to point out is CRP, which has consistently been associated with lung cancer in a positive direction in all of the studies that have looked at it essentially. And here we're seeing an inverse association. So it's unclear whether it reflects a different process, this is a different population, perhaps a different disease, if it's some sort of false positive, or if maybe it reflects some exposure in the population that has a suppressive effect on CRP levels and also is associated with lung cancer risk. So that one was a very surprising finding that's very hard for us to explain. And when we looked by latency, again, time from blood collection to lung cancer diagnosis, and we looked stratified based on the median. For soluble IL-6 receptor, this a strong association remains even 7.5 years prior to lung cancer diagnosis. So that gives that marker a little bit more, even more interest and credibility given the long latency and the remaining association. Whereas most of the other markers were associated within the 7.5-year period, which perhaps could give some evidence that maybe it's a tumor effect, or they could also be etiologically relevant. We also looked at covariates in this study. Because the causes of lung cancer are so different in this population, we wanted to understand how relevant exposures may also impact marker levels. So a personal history of bronchitis was not associated with any of the markers. There was some association with secondhand smoke exposure, which of course is an important lung cancer risk factor in never smokers. Though the data were not, the questionnaire data were not the best, the most refined, and they did have some information on dose of secondhand smoke exposure in a subset of our data, which also showed a dose response with these markers. And then poor indoor ventilation was associated with one marker. Of course, these were all adjusted for in our model, but it's important to sort of understand how exposures in never smokers may relate to these markers as well. So we must also consider that there could be potential residual confounding. We know it's not by active smoking because these are all never smokers, but either residual confounding by the covariates I've listed here, as well as there could be confounding by other exposures such as outdoor air pollution that we didn't have any information on in this study, or occupational exposures. So we compared the results from the Shanghai Women's Health Study to what we saw in never smokers in PLCO. Now, across the two studies in PLCO, we only had 83 never smoking lung cancer cases. So we didn't have a lot of power. The results didn't replicate from one study to the other because we were talking about like 35 and 45 cases between the two studies. But of the markers that we saw in the Shanghai study, 5 of them were at least consistent in the same direction as what was seen in PLCO and never smokers. Interleukin 21 and interleukin 10 were significant in the PLCO studies. The others were not, but again, it was underpowered. At least the associations were in the same direction, so that may provide some support, though I would not call it a replication of those results. The results were inconsistent for the other markers, but again, remember how underpowered the prior study was. And also keep in mind that the exposures in China, Chinese never smokers versus in the U.S. may be different, and these may be different diseases. So in conclusion, from the Shanghai Women's Health Study, 9 markers, again related to various aspects of the immune response, were associated with lung cancer in never smokers. The associations for the soluble IL-6 receptor were particularly robust when we stratified by latency, and also just the magnitude of the association and the p-value associated. Again, there's question about whether we are just detecting markers that are thrown off by tumors, but again, there was no association with increased stage of disease. That provides some, the associations were not stronger with increased stage of disease. That provides some reassurance. And it provides evidence for a role of inflammation in lung cancer etiology among never smokers. So I've presented a whole body of work using these markers in lung cancer and smoking, and I thought it would be good to kind of review from an overview perspective what the strengths and limitations of these studies are, and kind of talk about what is needed as a next step. So these were all large prospective studies, hopefully reducing the risk of reverse causality, and especially when you see associations with longer latencies. We had a measurement of a large number of markers simultaneously measured with good reproducibility. I didn't show the reproducibility, but the CVs and the ICCs were good for these markers. And we used all non-freeze-thawed samples to reduce the impact of having a thawing event and then a refreeze of these samples. And for the U.S. lung cancer, we did have replication of our results into independent sets of cases and controls. So the overall limitations of these multiplex immune panel studies, like I said, we need more evidence on how these circulating levels represent what's going on in the lung itself. Though we measure between 50 and 80 markers in these studies, there are many more markers of immunity that are not included in this platform. One real problem that we had with this technology is we believe that we're getting the right rankings of people. People with high levels have high levels across studies, and people with low have low. but the absolute values of these markers are not consistent with each batch of the assay. So it's very difficult to do anything on the absolute value level when you're going across studies. Within a study, you can look at it, but going across, these are not clinically certified assays like CRP, where a value of a certain amount means the same thing every time it's done. These are research assays, and you have to be very careful about that, making sure you don't have lot effects of the assays whenever you're running them. Like I said earlier, we were unable to really get at that mediation effect of cigarette smoking and the inflammation markers on the cigarette smoking lung cancer association, which would be an interesting question, but it was secondary to us really wanting to understand the etiologic contribution of these markers to lung cancer after controlling for smoking. So the need for future studies, as Dorothy mentioned, I really enjoyed doing this work, and I am happy to continue discussing it, but it's not my ongoing research portfolio. So there are a lot of future studies that need to be done to follow up on this work. So hopefully somebody out there is interested in is thinking about this. But for example, everything needs to be replicated in other study populations. We do have our results replicate, but it was within the PLCO both times. So it's the same age groups, mostly white, the same study protocol. They were independent sets, but it's not a different study population. It would be so interesting to see how serial specimen collection, measuring these markers over time within an individual, how those correlate to lung cancer risk and cigarette smoking behaviors, because nobody has done that yet. It's also a need to understand the correlations between local and circulating levels of these markers. And importantly, for understanding entrance criteria to LDCT screening, it would be interesting to further pursue the identification of other candidate markers that could be used for lung cancer risk prediction that are more specific to the lung than what we measured here. So with that, I'd like to acknowledge my collaborators on these studies. There were too many co-authors to list on this slide, but I wanted to note a few in particular, Neil Chaturvedi, Alan Hildesheim, and Hormuz Katki, who were crucial in these studies at NCI. Our laboratory partners at the Frederick National Laboratory for Cancer Research that do all the multiplex immune testing for us, Leisha Pinto and Troy Kemp, as well as their team. And then our contractors at Information Management Systems who help us with case control selection and some of the statistical analyses that we presented. So with that, I know we don't have a lot of time, but I am very happy to take any questions that you might have.
Yes, it was a very good study. I'm wondering if you looked at you said the term lung cancer, but there's many different types. There's small cell, adenosquam, large cell.
Yeah.
If you use that, do any of the markers stratify further?
Oh, so you're asking about the risk stratification piece of it, or are you asking about the lung cancer just risk, the associations with the subtypes?
Yeah, either, I guess.
Okay.
Did you see any further?
Yeah, so we looked at, we didn't see significant differences. There was no significant heterogeneity between the associations when we looked at squamous cell and adenocarcinoma. The other subtypes, there weren't enough cases really to do much with, but the associations were consistent with those subtypes. In the never smoking study, we could only look at adenocarcinoma. The other subtype, they were either missing or the other subtypes were too rare, and the associations were generally consistent. So we're not seeing real dramatic differences where the markers are only associated with one histology of lung cancer. For the risk prediction piece, we didn't try to do risk prediction for any particular histologic type. The results, I didn't present the results by histology, but they're in the papers, and I'm happy to send it to you if you're interested.
Very nice talk.
Thank you.
My question is, have you or anybody else looked at effects of taking anti-inflammatory drugs? Smokers who take them long periods of time. Is there any effects on risk?
So we did do another what I would call value-added study using that same data source that we did the cigarette smoking analysis in. We didn't just look in smokers, but we did look at NSAID use. There wasn't a lot. I will use the caveat that the questionnaire data on NSAID use in the PLCO is not ideal. So there weren't really strong associations. Certainly, I don't know if anything passed a multiple comparisons cutoff, but we do have a publication on that if you're interested. We didn't look just among smokers, and as I said, it was not the right setting to get a real detailed assessment of NSAID use. I can't remember what the exact, I think it just was maybe one question on frequency. I don't think we had dose, for example.
So, just one technical issue. Did you make adjustments for batch effects? I mean, I'm aware of the aluminum, or what the issues are with it, and that's one way of handling it.
So with the batch all of our cases and controls, because they were matched, they were all cases and controls were aliquoted onto the same batch. So because cases and controls that are matched together are only really being compared to each other statistically, that took care of the batch effects. There were severe lot-to-lot effects of the assays, which is what I was referring to. But within each study, it was only one lot. So we didn't have lot effects within a confined study, and the cases and controls were batched together.
So are these markers statistically independent, or they might be correlated?
So that's a great question. It depends on the markers you're talking about. I was expecting, whenever we did this study, to see just very, very strong correlations between all of these markers, and they weren't as strong as I expected. So some of the markers are correlated, but they're not correlated at a 0.9 level. They're more of like a 0.4 sort of level. So we did play around with some different approaches, statistical approaches, to try and group markers based on their correlations, like primary principal components analyses and that sort of thing. But it didn't really add much to the findings that we found. And again, the correlation coefficient matrices are all in the supplements of the papers if you're interested in how they correlate.
Hi, thank you for your talk and very nice work. But I have not really a question, I guess, but two thoughts I can't shake. One is that inflammation is just in the causal pathway between smoking or the other risk factors we might think about with lung cancer. And then two, that there could still be very early lung carcinogenesis that's then driving the inflammation. And I'm not sure that it sounded like you couldn't answer the first causal pathway question because you matched on smoking.
Yes.
And the second one, the time frame that you suggested might argue against that, could just be pointing to much earlier carcinogenesis than which we're aware of.
Absolutely. So, like I said, we can't really quantify that inflammation effect on the smoking to lung cancer pathway. That's why we matched our study so closely on smoking, because you can't really, people will not be convinced if you don't try to account for smoking as tightly as possible. It's possible there's still residual confounding. The fact that we didn't find associations with smoking in our other study, though, sort of argues against at least that part of it. You're right. I mean, how early is there a lung cancer there before it's diagnosed or even clinically detectable? It may be throwing off immune markers, a decade in advance, and we can't account for that in our study. We can just say it gives us a little reassurance that associations are seen years before, but it could just be a tumor marker. You're right.
So that doesn't bother me. So because I think your matching makes a compelling argument that there is interindividual variability in inflammation that is not about smoking. So what factors could you look at in PLCO that you didn't match on that might explain that variability?
So, I mean, do you have ideas? We looked at personal, self-reported emphysema and bronchitis. It didn't make a lot of difference when we adjusted for it in the model. There are things like age and BMI, which are adjusted for. you're sort of limited by what questionnaire data was collected. So, NSAID use we looked at and adjusted for. We really, I don't know. I mean, I don't know if there was a particular exposure you had in mind that you were interested in.
So is your money on it being residual confounding or some other trait or exposure?
My money, I guess, is on there it being some other exposure or interindividual variability in the reaction to cigarette smoking, for example. So it's not confounding by smoking, but the smoking is still a causal factor, and different people react in different ways to smoking.
And I don't think you showed it, but did that hold true in the non-smokers? I know it was a limited number, but do you see that interindividual variation in inflammation markers mattering for risk?
The markers were not consistent with so the vast majority of cases were either current or former smokers. And between current and former smokers, the associations were consistent. Never smokers the data were so sparse that the estimates were sort of all over the place, and they weren't necessarily consistent with the overall findings.
In the PLCO data, did you look at perceived stress of the individuals as that could contribute to their inflammation?
I don't believe we did not look at that. I don't believe they have that information. It was a screening trial, so, they collected a lot of relevant information that could be used, for epidemiologic studies, but I don't know that they collected that.
In the study that you are recently completing in the Chinese women, the air pollution, particularly around Shanghai, is notorious, particularly called the brown fog. I have no idea where your locations were. Did you track that with either Google satellite or something else and try and integrate it into your data as a potential confounding variable or a unifying variable for the women?
That's a really interesting suggestion. We did not. I'm a little less plugged into the Shanghai Women's Health Study. I've done less work in that particular resource compared to PLCO, so I'm not fully aware of all the work that they've done. I don't think they've done something like that, but that's a really interesting idea. And certainly we don't have measurements of air pollution, so that could be one of the driving factors here. There are a number of, in our occupational epidemiology branch at NCI, there are a number of studies looking at occupational exposures, that smaller studies among workers that are looking at these markers. So they found some associations with diesel exposure, for example, and actually that's one that was consistent with a decreased level of CRP. So maybe that's some sort of an explanation that diesel-exposed workers have lower CRP levels. So. But that's a really interesting suggestion to look at the air pollution maps. Thank you very much. Thank you.